Hello, my name is Zach, and I'm a first-year medical student at the CUNY School of Medicine.
Hi, my name is Amar. I'm a rising senior and econ student at Case Western. Welcome to the MSX podcast, a show about a broad range of topics in medicine, from education to exploring research and contemplating future directions for the field. In each episode, we speak with leaders in the field to learn from their insight and expertise. This week, we have Dr. Malik, an interventional cardiologist at Maimonides Department of Cardiology. Dr. Malik played a pioneering role in converting Maimonides Med Center into a 100% primary PCI program. He has a keen interest in research and has been an investigator of multiple randomized trials, as well as an author of multiple journal articles and book chapters. So for the first question, I'd like to get, a more broad understanding of your career journey and maybe what sparked your interest in cardiology.
Medicine in general is considered a very noble profession, and that's probably what drives most people. You may see at a younger age, what are the dreams of any kid? You want to be a firefighter, you want to be a pilot, you want to be a nurse, you want to be a doctor, anything which you believe you can contribute, and that's anybody's dream usually. And as you grow up, things change. Somehow, if I can say that, my grandma used to be sick a lot, and during her sick times back home, you looked up to doctors, and when they came in, and it gave you hope that things are going to happen now. And you wanted to be like them. You want to be that person which you're looked up to, with hopes that you can change things. I guess that must have been the very early thing, And again, as I said, it's a very respected profession, noble profession. Even financially, people don't do that bad. So considering all this, probably it sparked an interest early on in medicine in general. And about cardiology, how do you like cardiology? One of our earlier program directors here used to say anybody who comes from overseas, it's an autosomal dominant trait to be a cardiologist. Everybody wants to be a heart doctor. And gradually they realize either it's not their interest or it's too hard or something, and then they start deviating into other things. But somehow it's been most people, somehow when they join residency, somehow cardiology becomes the first love. It's intense, it's something, especially heart attacks when people are really dying and your presence there can change the whole scheme of things. It's very enticing, very people feel very empowered, and people feel they can, as I said, contribute very positively there. It makes instant gratification is there, especially in interventional cardiology. That probably is a big rush. That's what people like. And there was an interventional cardiologist from Washington, D.C., who was a Kashmiri in origin, who did very well. And he used to come back home from lectures and stuff. So that was a huge impression on you. You wanted to be like him. So that probably prompted me to like and somehow get into cardiology.
I was wondering about that mentor you mentioned. Were there any particular traits that stood out to you in him that you wanted to emulate?
The problem is I don't want to mention names here. For some of his traits I may not like, and that's why I don't want to mention names. But to be honest, one of the biggest things in him is I remember back home he was not supposed to be academically a good student. And a professor back home once said on rounds that when they were told that he was doing so well in the United States and he was making land-breaking things and doing great work, he said he could never believe it till he went down and saw him operate with his own eyes. And that is the only time he believed he could just do it, because he was not known to be that great a student. So I think to his credit, it's very important. Just being academically good student is not enough, or that's not a gold standard. Doing well in exams, which we all look back home, that was the criteria for everything. If you were top of the class just because you did great in the exam, that's not enough in life. There's much more than exams. And sometimes I tell even my kids the same thing. You just got to take these exams because you have to take it. I don't think they're an absolute test of anybody's ability. but you have to go through them. So that's a part of life. But you can, as in his example, he did so well and proved everybody wrong.
Mm-hmm.
That goes to his huge credit.
So, what are some of the qualities you think are very important in your field?
See, I feel they are important in any field, irrespective of everything. We train a lot of residents and fellows. Uh, See, for example, in interventional cardiology, what I tell them is like, no, in interventional cardiology, you get called at odd at times for an acute MI, and it may be midnight, it may be 2 a.m. And when you're early and young and you want to jump in and you want to go in, but gradually that sometimes dies down. And my advice to them is that if you are ready to jump out of your bed with a smile on your face at 2 a.m., then this is for you. If you start kicking things and cursing people, oh, run out again, I was just going to sleep, then there are many other things. You can probably make much more money doing something else, even in medicine, even office-based medicine. This is not probably financially as lucrative as anything else, as dermatologies and as plastic surgeries or whatever. So that should not be your kick to do this. It has to, like anything else, it has to be a passion. If you really want to do it, again, for you guys also, like uh, even in general schooling, my philosophy is that first maybe even 5, 10 years or building years of anybody's career, schools should, rather than teaching everybody everything, I think teachers should be taught to recognize that fire, that spark in that person. What does that person want? And direct them that way. Somebody's excellent in maths, direct them that way. He doesn't have to do something else if he really wants to. So if you feel that that is where his passion is, follow that passion. You will do very well there. You don't have to try and do something else. That example for kids from India who do great in those IITs and score, beat hundreds and thousands of people going to those IITs and come here, do MBAs, end up working for a bank. That's a shame. It's just that if you have absolute passion for a thing, even if it is cleaning floors, you will be the best at that. And you will make a difference there. But if you're doing a job just for the sake of doing a job, you'll be an ordinary person. You probably will make an okay living. That's sometimes not enough. No, like there are hundreds and thousands of kids who try out and say basketball or tennis and stuff, but only people who make it big are people who dream it, who drink it, who wake up during the night. That's what you do. If that is in your blood, that's what you want to do. Somehow the greatest effort should be to find that niche in any kid. What is that which drives you crazy, which you really want to do every moment? It doesn't matter. Like, no, it's your pastime, it's your free time. That's what you think about. If you pick that, if you get that, you will. I don't see any reason any person should not be successful in that.
Mm-hmm.
I guess jumping off from that, in regards to passion, would you be able to speak about a time that stands out to you as a high point or a peak in medicine, like a moment where you felt the most effective, alive, engaged, just feeling that type of passion that you were talking about?
See, again, good and bad part of medicine, especially interventional cardiology, is that now everybody see, for example, in this country, an attorney takes one bar exam, is passed, and he's done with exams. A financial professional takes that exam, he's qualified as a finance, he's done with exams, all right? But a medical professional may take a million exams, which we have to take every 10 years, and still he's not done with that exam. Every patient is an exam, right? Every time you face a new patient, then there are no similar patients. They will have something different, even if they present with the same thing. So you're faced with an exam every day. Good part is like now in interventional cardiology, we get these emergencies, obviously heart attacks, and people are, I can narrate 100 stories when people were bought dead and somebody thought they were gone, and you went in, you open up, and somehow they wake up. I can tell you stories vice versa when I thought that we did a great job and he should wake up and they never do. Kind of diverting from that, lots of times Uh, to be honest, no, I'm not a very religious person, but my faith comes from my work, absolutely. And I discuss that with my friends all the time. Like now, uh, I have seen we do everything possible, everything is going right, and something happens and it just does not work. And vice versa, when things are going totally downhill and things start showing up, and whatever you didn't do anything differently, and it works up. So then makes you realize that sometimes maybe sixth sense or something, you feel things are working this way, and somehow you have to have that connection to pick those small things, small signals up and utilize it. It's a surreal feeling. It's very hard to explain what that is, but that's once you experience it for yourself, you will know what that is. That's over and beyond any kind of a logical or a scientific explanation for that.
And I think my next question is going to be going back to the journey, right? So I'd love to hear more about your experience adopting to the U.S. healthcare system after going from Pakistan.
See, I'm from Kashmir. Kashmir is basically a place between India and Pakistan, which they kind of fight for, because everybody believes this is theirs. That's a different political situation, but that's where we're from. See, as with any Southeast Asian country, probably there's a lot of focus on academics. There's a lot of focus on numbers. There's a lot of focus on getting first down there, getting 100% all the time, which probably is not bad. But again, in education, that it's not a wholesome education that way. It's focused towards getting numbers, right? Getting 100% any exam, which sometimes is a limitation. But at the same time, I think what we lack here, knowing and training a lot of medical students and residents, is that they don't have that sound basis of their. Somehow, I haven't seen hardly any medical students read textbooks. Their bases are not as strong as anybody trained or who has gone to medical school in any South Asian country, be it Pakistan, be it India, especially if you're going to top tier medical school there and have done very well, who most of them have done well, and that's why they end up here. Academically, book knowledge wise, they're way ahead of anybody here. And you would be surprised that there is data from this country that patients who were treated by physicians who were trained abroad do much better than patients treated with physicians who were trained here. Wow. We produce tons of subspecialists, but they are very good and they're very subspecialty. They're in their niche fields, but they somehow cannot correlate the whole thing because their depth of knowledge is not there. They have knowledge and their subspecialty, but they don't have a total hold on the whole subject because they never read to that extent. They read their own small booklets, exam pass things, those like condensed things. That way, if you talk to anybody there, somehow we used to memorize textbooks. Like memorize, they will tell you on what page, what side, upper right side, it was written in red color and the graph was on the upper corner. It's like crazy. Again, which I don't think is needed, but at the same time, that gives you a lot of comprehensive information. It's drilled into you. You're forced to do that. Unfortunately, memorization is the effect, but in medicine, it's so vast, you cannot memorize everything. So you somehow have to find a connection, how to keep that knowledge, and that only comes when you interact with, when you correlate with patient care, when you correlate with patients. There is so much here. There's no way you can memorize everything. I think that's one of the major differences. For example, one of the conditions which COVID gives you, it's a respiratory failure called ARDS. It's a different one than the regular ARDS, but as a medical student back home, I knew exactly how to manage it, but I had never seen it done. I could tell you all the steps, but I had never seen a ventilator being worked like that. Here you have more practical experience. You see all the gadgets, all the latest things, how to use them, how to do them. But the kid there who may know exactly, but he's never seen it. He's never experienced it. So that's a different ball game. They work within their own limitations, and unfortunately, which one of the reasons somehow I also left, because it was heartbreaking to be limited by uh, not able to do give this. That was very heartbreaking sometimes. Not that leaving there that was an answer, but kind of most of us, I can tell you of mine, my friends came here for academic excellence. They did not come here to make a good living or make a good life, because thank God our life back home was much comfortable than the life here. But then political things and stuff like that, we somehow got stuck here. There's an interesting story on that. I interviewed in Cleveland Clinic for a medical position for a second year, and some of the chairman of medicine from was kind of from the same place I am. And after all the interview process, I sat with him for just a courtesy interview or whatever. So he told me what your goals are. I said I want to do interventional cardiology and go back home. He looked at my face and says, "There's no home back home. This is your home, and I will guess that you should learn to live here." And he told me that time, interventional cardiology is not the right thing to do, because if you had come when I came, that was the right thing to do. But right now, those days, it was family practice was big thing. You should do family practice, make a good living, settle down, and that's the right thing. I came out of that room furious about, oh, he's married to a white woman here. He's lost just totally, I want to go back home next time. So he was probably partially right. I did interventional cardiology anyway, but I somehow did not end up going home as of now, although the dreams are still there. One of the dreams is building a hospital or working and giving people there the same kind and level of care which we have here. We can talk about that some other day. We have done some work there as a part of an NGO, but that dream still is there.
From your experience then to the time now, is there any way that you've seen cardiology change as a field? And do you have any directions or ideas of where it's going to be going in the future?
See, cardiology has evolved tremendously, meaning the level of cardiology practice in this country is incredibly at a high level. God forbid, most of people who end up as a heart attack in most hospitals in this country, if not all, will be taken care of right away and will get to the cath lab or a clot busting medication right away. Like we have certain parameters to feel people, hospitals who give just clot busting medications, very few of them in this country now, have to give it within 30 minutes of it. Or like people who go to hospitals like ours, where they come to the cath lab to get their artery open, we have what's called the door to balloon time. You have to technically do it within 90 minutes of it. Every hospital has to report this data to ACC and national agencies, so these things get monitored. So who's taking how much time or whatever. Uh, that makes it a much, much higher level of care. You can see, I can tell you a story of a person who got a heart attack in Kuwait. Somehow from Kuwait, he went to Iraq. From Iraq, he ended up in Karachi. In Karachi, after around a week's time, he got an angiogram. After the angiogram, they told him, okay, these arteries are blocked, deposit this much of money, then we'll open up the artery. So after the next 3-5 days, 2 weeks elapsed between his heart attack and this. That means the muscle which was affected was dead by that time. It was stupid. He somehow was alive, but that's a different level of care. So here, the level of care is tremendous. And like now, if people end up needing a bypass, most of them emergent bypass will be done the same day. It's unheard of in the rest of the world. And I don't want to kind of boast of the care in this country. That I understand expensiveness of this medicine is it comes at expense, and everybody is very worried about that. But the universal health care and stuff like that, which is very enticing to you guys at young age, which is very nice, but unfortunately that comes at a huge price. It's not the same level of care in any such countries, whatever the numbers say. England, Canada, it's not the same amount of care. It's not the same level of care. See, anybody here, even without insurance, who ends up in any ER is not denied care at all, gets the best care anyway. Whereas, as I said, it comes at a price, that's true. Healthcare is a huge expense, but that does not mean that there's a fault with the system. There are other things which can be really fixed if price has to be addressed. But why does it happen that anybody in any country in the world, if they get sick, the head of the state gets sick, why does he come for care in the end? He comes here, be it from Europe, be it from Middle East, everybody comes here for the level of care. So that's has to be borne in mind by all of you. That it may come at a price, but the level of care in this country is absolutely top notch.
So I
As
think
for future directions in cardiology, like now even in interventional cardiology, there's a lot of AI being involved, robotic surgeries being involved. There's going to be robotic interventions coming in down the road, uh, which will probably take some time, but still is this huge advancement.
I'd love to hear more about this advancement in AI in cardiology, and maybe what skills of a cardiologist will change as we see more AI and robotics in medicine.
See, in radiology, at least, there is again data that CAT scans read by help of AI are most of the times read as good, if not better, than read by a human sometimes. There are different limitations to it, but it's an evolving science. Like now, certain things can be exactly done by that. If for example, there is a picture interpretation thing, that's not a big deal for AI to figure out, because they can do measurements to the millimeter or half a millimeter and stuff, which your naked eye may not be able to do. Or they can see lots of interpretations. Sometimes I don't know, somebody is not in a good mood, the picture quality is not good. Doesn't have such limitations, right? So human factor is taken out of that. But there's in medicine, there's a lot more which being a doctor is important, because again, as we said, that correlation thing, which people don't have here sometimes, is not just about one picture, it's not about one test. See, again, treating the heart, brain, lungs, kidneys, skin, they don't function independently. It's one composite system. So to get everything into one, like now when things change in heart, things change in kidneys also, things change in brain also, to get everything in cameras in one is going to be an enormous task. But yes, bits and pieces can be taken care of. Like now, see, robotic PCI, robotic intervention is if you want to give out a particular area which is well researched, well documented, can work, yes, you can do. But having had, see, if I give a set of complaints to you, like somebody came to emergency room with cough, headache, this and that, exactly the same age, same presentation, everything else, right? And you have an algorithm devised, they will give you 5 differential diagnoses or 6 differential diagnoses. But for a physician who's trained, who looks at his face of a person, he may say this is all nonsense. He doesn't have anything, because he gets that physical impression that somebody may be just like that. We get that all the time. See, for example, there are patients who come with the typical chest pains and all the time to emergency rooms for nonsense sometimes, and they have lots of times psychiatric issues and other issues which are not accounted for. So to get everything in one place may not be easy, but bits and pieces, I think it will make leaps and bounds. Going forward, they can probably incorporate more and more things.
Prior to this interview, I was looking specifically about some of the innovations in cardiology, and I found TAVR or TVR, transcatheter aortic valve replacements. I was wondering how they've changed the state of cardiology, and what new innovations do you see from that?
See, when we start, like even when I started, the only way you could replace aortic valve was open heart surgery, is that right? Now, fast, probably 13 years or so, it's almost been approved for the last 13 years. First, it got approved in, I think it was 2009 or so, for very high risk cases, which were considered surgically inoperable cases. So now it's approved even for lower and lower risk cases, intermediate and lower risk cases. So you can imagine somebody who had to get his chest cut open for a procedure. Now we do it like a regular angioplasty through a groin, and patient can go home next day or in 2 days without a chest being open. That's a huge advancement. And right now, what we do, there are 2 valves approved in this country. Medtronic and Edwards. They have each little different features which can be used one and the other depending upon the need of that person. And it's a very, very convenient and easy. It made life very easy for us and for patients also. So in my place, we do around 100 to 125 hours a year. And that was kind of 100 cardiac surgeries before, open heart surgeries before. And it's just taken over the whole surgical field that way. And now it's going to be coming up for the mitral valve, for the tragus valve as well, because they're a little more complex to devise, but there are trials for both these valves too. But the commonest disease after the age of 60, 70 is aortic stenosis. That's probably the commonest disease elderly people have in this country. So that's a huge relief to a huge chunk of population. And it's a routine procedure we do, and we do it every week.
If there's one metric we could track, like one biometric everyone should be tracking, what would it be? If we had like unlimited technologies, what metric should we be tracking?
Metric which you probably, everybody has there would be no metric probably for, I don't know how to gauge that, should be probably happiness. So you can have two people with absolutely similar things and similar, whatever, financial situations, similar everything, and somebody's very unhappy. It doesn't make any sense. Somebody who has probably limited resources and is happy is better off all the time, is that right? As regards health, is there a single metric? One of the issues in this country is obesity. That's an easy metric to have. Usually I tell my patients all the time, if you have a 400-pound person sitting next to a 135-pound person, same age, who's going to be alive 10 years later? Simple. You don't need to even see what conditions this guy has, what condition that guy has. The 400 LB person is not going to be alive. As simple as that. At the same time, another thing I use lots of times for patients is that's my personal experience. Patients who keep their appointments, who are compliant with their medications. See, if I have 25 patients to see in the office, I will know 100% these 15 patients are going to show come what may. Other 5 may or may not show, and 4 of them, I'm sure they may cancel or reschedule, stuff like that. Again, 10 years later, I can assure you those 10 who were compliant with medications, who showed up their appointments, all 10 of them are going to be alive. It's a natural thing. It's something lots of times when you take your health seriously. In fact, I go to the extent that when people get heart attacks at a young age, it can be a blessing in disguise because they wake up to their healthcare needs right away. Otherwise, a 40-year-old is too busy with his life. He doesn't care. He never goes to a doctor. He doesn't take care of himself. But if he gets a heart attack and he realizes he's going to die now and stuff, now he goes to a doctor, he takes medications, he takes his diet seriously, he takes other things seriously. It's a wake-up call for him. He might, in the long run, do better than somebody who may not have had a heart attack but took his things lightly and ended up being diabetic, ended up being obese, ended up being some worse without having any major events. That wake-up call may be very important. That doesn't mean everybody should get heart attacks, but I'm saying sometimes it works to your advantage, the way you take it. And again, there's a big issue with that too now, and that our procedures are getting minimal and invasive, meaning when I started, the only way we did angiograms was through groin. Now we do around 80%, 90% angiograms through the radial artery from the hand. So it's much easier, much more convenient. We used to put those sandbags on your groins for 4 hours, 5 hours. So people thought that this was a huge procedure. Now they come in, even with a heart attack, you go through the arm, procedure is done in an hour, in a day or two you're home, you feel there's nothing happened. It's very trivial and people don't seem to get the importance of it. At the same time, if you get an open heart surgery, your chest is cut open, you have multiple tubes coming up your mouth, chest, heart for 3-5 days. You take life very seriously after that. And everything changes. The major thing happen, but it's a lot that the team has to make sure that people get this idea that this is not, it's not a joke. I can tell you an example of a patient. He had multiple heart attacks. He came for one more heart attack. One of the stents was blocked, and I was trying to open this up. It was a very terrible, difficult procedure, and I thought we'll give up. He may need emergency bypass. Finally, somehow we got through. We opened up, and everything is fine. So I was sweating. I told him, "Listen, like, no, you came so close to having a bypass, and this doesn't take your life seriously. This, with all the lecture and everything else." He said, "Okay, that's all good. Can I go home tonight?" So whatever I tried to convey for half an hour, it fell flat on him. So if he had bypass surgery, he would have been totally, totally worried. So that's somehow how to, it's not about scaring people, how to make people realize importance. It's not just doing a procedure, it's the whole team effort to make them understand that, what it means. Maybe show them videos or maybe show them data of how many people die of heart attacks right away. You're lucky. And one of the lines I use all the time with my patients is that when they come with heart attack and make sure they go home safe, that this should be your second birthday, because people die of heart attacks even before reaching home, especially within the first hour. Most people, if they get VT, VF, arrest at home, they die and they never reach in the hospital. So now you're alive, then this should be your second birthday. Sometimes, getting to give them the gravity of situation and just making them understand this really helps in management in the long run. Otherwise, people take it very easy. And one of the things people use who have kind of religious faith, there's nothing against that. Oh, God has given me this much time, I don't care. I will die when I have to die. Who cares? Which is not the rightest way. It's very difficult sometimes how to get around it. Because at the same time, God has given you avenues. No, if you don't just jump off a building and say, "Okay, that's fine." There is a staircase. There's an elevator. You can just jump off 20th floor. So if I have to die, I will die. I will reach down anyway. But chances are you're not going to be alive on the ground if you just jump off. So God has given you mind. God has given you avenues to path, and you have to realize to take the right avenues. So it's sometimes a tough, difficult task with people, but you, again, unfortunately, lots of people have less and less time these days. But more time you spend, more explanations you do, and then develop a relationship with the patient, they have to trust you. So I tell this patient the same thing. If they don't trust you, there's no point following up. It's just useless. There's nothing wrong in getting second opinions, third opinions. I welcome people, go check with somebody else. That's fine with me. But at the same time, if they don't have faith in you, if they don't trust you, it's useless. There's no point following up.
I guess another question regarding your, patient relationships. I was wondering if you could tell us about a patient that touched your heart and a patient that changed your practice.
Picking up one patient would be very hard. Like now, my problem is it's not just about one patient. I usually get involved in patients, meaning I know their families, I know what's going on with their families, kids, and this, and that gives you that relationship with the patient, and that gives you insight to the other things, what's going on. Sometimes, unless you kind of go into those details, you will never know them. I can give an interesting story. I have a lot of these elderly ladies who have to go back to Egypt or Pakistan or India. When they come to my office and I see a smile on their face, I know they probably are going next month back to their home country. At that time, they don't complain of anything. Everything is fine. No chest pain, no sharpness of pain. They don't want to open up a can of worms. They're happy because they're going. They will not complain of anything. And this very interesting patient she's an elderly lady, and her two daughters take lovely care of her. Like, I have never seen the son, but daughters bring her in every time or whatever. But when I go into the room and if I see she's not in a good mood, do you know what the answer is? Answer is her son has not called for the last couple of days. If she is smiling, probably her son called last night. These are interesting dynamics sometimes. No, it is what it is. It's very sad, but You got to know other parts of it. Know what's going on with their lives, spouses. There are stresses at work, financial stresses. They all come into play in managing a patient. See, I tell even residents and fellows sometimes they write the top-notch medications for them, like no, this. If their insurance does not approve it, and lots of times these pharmacies don't fill them up because they know they need a copay of $500 for this, and these guys lots of times may not be literate enough to call for a replacement or whatever. End result is they don't take the medication. So there's no point giving them these high-end medications if either you first don't make sure that their insurance approves of it or they are capable of taking it or capable of doing it. It's better of giving regular random medications which can help them, making sure they can take them. So sometimes again, that again has to be balanced out sometimes. It can be very tricky. As I said, like taking good care of these people, sometimes it takes a lot more effort, a lot more time than usual. And that's a big limitation. And it's not rocket science, it's common sense most of the times. But somebody has to do it. Your team or whatever you have, a nurse practitioner, a PA and stuff. And if they are caring enough, if they understand the dynamics, at the same point, like a profession of nursing, it's huge. It's not easy doing that. It's not easy cleaning up somebody's vomit or somebody's diarrhea every day or somebody's smelly. It's a huge commitment. If you're not there for the passion, there's much more money in tons of other things. It's not if you start somebody throws up and you, oh my god, I'm not going to that room, they're so smell, then this is not for you. You can do something else.
Thank you for your time, Dr. Malik. As we wrap up, if there's any final words of motivation or words of advice, best resources that have helped you along the way, anything for people aspiring physicians.
See, I think there are two things which we probably repeat a couple of times. One, you got to find where your heart lies, what your passion is. That's very, very important, and follow it. Again, it's more kind of a global thing. If you go into it for wrong reasons, it never works. Meaning, if you go into it to, oh, I have to be famous, or I have to make money, or I have to do something, like I have to be chief of this, that's not the reason to go into anything for. I give the story everybody that I don't know if you follow cricket. Sachin Tendulkar was one of the big Indian cricketers, and at the age of 14, with his other classmate, he made a huge world record of some 700 something run partnership. And he was interviewed that time. I don't think somebody coached him out. It came out of his heart. He was told, oh, what are your plans now? Are you going to be playing for India? Are you going to be an Indian captain? Are you going to be this? And he said that my coach told me, go out there and do your best. That's what I know. That's what I do. If everything else has to come, that will come to me automatically. My job is going out and doing my best. I think that's a huge line to know. You go out there and do your best. Rest, finances, positions, they come and go. If they have to be in your destiny, they will come. And lots of times you get very disheartened as young people. Oh, my colleague, he did this, he got a better car, he got a bigger house. It's in the end, it's not about that. It's about much more than that. In whatever way you believe in. Again, that as I said, that personal satisfaction, happiness, you go to bed and are able to sleep comfortably, that no, you're not afraid you did something wrong, something crazy, you didn't hurt somebody, at least consciously. Unconsciously, you may not be able to help. That's the greatest feeling you go with.
Thank you so much, Dr. Malik.
See you guys next week. Thank you, Dr. Malik.
Thank you for having me. It was a pleasure all the time. All the best.